So I'm going to get started now. Here is our program for today. We'll be hearing a few words from our board president, Janet, and then a few words from our our sponsor, Dr. Conrado Barsaga, and then we'll get into the presentation of the results. So I'm very excited, and right now I'm going to turn this over to Janet, who is unmuted. And welcome, Janet, and thank you so much for joining us.
Thanks, Jenna. It's a real pleasure to be with you here today. And I really want to extend my welcome and thanks for all of you joining this webinar for the release of the 2019 Coachella Valley Community Health Survey. We obviously tremendously appreciate your participation today, especially given the extraordinary challenges that you're all facing from the COVID-19 pandemic. Thanks for all that you are doing. I also want to call out HARC and give considerable credit for them doing all that it took to make these data available to the community on the original date. Thanks too to the City of Palm Desert, who supported flexibly this release as it transitioned from our in-person meeting to our video conference. As for the prior 4 surveys, this 5th survey describes the progress and the continued needs in the Coachella Valley as we strive towards health and wellness for all. But I think we should also recognize that this survey is quite unique in that it will also serve as a critical baseline to the health and social effects of COVID-19. In other words, these data finished collection during December of 2019, just prior to the impact of the pandemic. So I think it's going to be very important data for us to be able to track both the short and long-term effects of COVID-19. I want to recognize and thank the many funders who make this work possible. The survey's primary funder, of course, is the Desert Healthcare District and Foundation. They are both the primary funder and a close partner in the effort, and you will hear from them momentarily. The range of funders are going to be shown on this slide as well as the next. And really, it's only possible to make this critical data free of charge to the whole community by having all these funders come together to make this a reality. Your funding is really a direct contribution to the entire community. You will see all of these funders recognized in the final report, and you'll also see many of them highlighted in local spotlights showing their work within the report. You'll notice Friends of HARC at the bottom there, and these are individuals who make personal contributions to the effort. HARC puts every single dollar to good use, and we also deeply appreciate the many in-kind contributions that were made in support of the survey. Let me wrap up by saying what a tremendous resource our community has in HARC. I spent 30 years at the Centers for Disease Control conducting state and national health surveys. And I can promise you that it is extremely rare to have the kind of capabilities that HARC has within your local community. Expertise in survey design, in program evaluation, in data analytics. So I know you know them well, but I just continue to highly commend them to you when you need help with program design or data analytics. Finally, let me extend my sincere concern for you and your families during this difficult time. Please take care and all be well. And with that, Jenna, let me turn it back to you.
All right, thank you so much, Janet. I'm going to change your role to attendee now so you can enjoy it with the rest of them. Thank you for tuning in. Okay, I do want to, I realized I already skipped a slide. How have I done that? But I did want to acknowledge that today is Cesar Chavez Day. It is also the anniversary of his birthday. And I think that's something really worth mentioning and worth emphasizing. Cesar Chavez was a huge, had a huge role in the Coachella Valley and really was interested in speaking for the people. So I think that syncs up very nicely with HARC's work and HARC's survey here. This quote that I picked is one of my favorites of his. "We cannot seek achievement for ourselves and forget about progress and prosperity for our community. Our ambitions must be broad enough to include the aspirations and needs of others for their sake and our own. I think that HARC survey is an important step in measuring progress and prosperity for our community, especially since we measure time and time again. This is our 5th survey. So I think that is very much in the spirit of today. Now I'd like to introduce you to Dr. Conrado Barzaga with Desert Healthcare District and Foundation. He is the CEO there. And welcome, Conrado.
Thank you, Jenna. On behalf of the Desert Healthcare District and Foundation, I want to thank you for the invitation, and I also want to welcome everyone who's attending this virtual presentation. I wish everyone is healthy and staying safe for themselves, for their families, and for our community in Coachella Valley. I also want to acknowledge HARC's heroic effort in completing this health monitor. I know it has not been the easiest task, and especially in these times in which we're facing an outbreak of a pandemic that it's having a profound impact in our community. This health monitor provides valuable data to all organizations in Coachella Valley, not only healthcare providers, but also policymakers, policy analysts, social service organizations, employers, and the business community in general. The data collected by HARC is essential to reliable and valid public health research. And I want to invite other organizations that are participating, or those that might not be participating today, but will have access to this data, to find ways to use, analyze, and apply the knowledge that this health monitor provides to all of us, because data is only useful if used, analyzed, and applied in a timely manner. Data, it's also important to evaluate the impact of our existing programs in Coachella Valley. It is important to determine appropriate healthcare delivery and public health interventions, to monitor progress, to identify community needs, and to determine populations to target for an intervention, to determine barriers to care, and to influence public policy. I believe it is important to acknowledge also that the outbreak of COVID-19 has exposed gaps in our healthcare system, our healthcare infrastructure we had not talked about before. And it is important that we work to address in the near future the gaps that this outbreak has exposed, and that we continue to work together to gather data to analyze the needs of our community and to create a stronger healthcare infrastructure for our Coachella Valley. Again, I want to bring this back to Jenna and HARC, and thank you, Jenna, especially for all the hard work that you have put on making this report available. And again, welcome everyone to this presentation. Thank you, Jenna.
Thank you so much, Conrado. And again, a huge thank you to Desert Healthcare District and Foundation for funding a large component of this survey. We absolutely could not have done it without you. So, Conrado, I'm going to turn you into an attendee now. It's midnight and you turn into a pumpkin. Thank you so much for joining us. Okay. All right, everybody. So I am going to now share with you what you've all been waiting for. But first, I wanted to point out, again, for those of you who joined a little bit later, this is a webinar versus a meeting. So if you have anything that you want to chime in about, just please type it in your Zoom chat box. You can address it to all panelists, which at this point is me, or you can address it to all panelists and attendees so that everyone can see your comments. We also will have some live polls, so stay tuned. This is a participatory type of event still. Naturally, it's not as participatory as I would like since I don't get to see you all in person, but we try to still keep it interesting. So get ready. So first of all, I want to tell you a little bit about HARC. We are a nonprofit organization founded in 2006, and we strive to improve community health, well-being, and quality of life through data. So we're data geeks. I have this photo that is fabulous. It is a little bit old because we have one new staff member since then, but I want to give a huge shout out to my team. They are absolutely amazing, and as Conrado mentioned, this was not easy this time around. Well, it's never easy, but it was especially not easy this time around, and they really made it happen and made it happen in a timely manner. So HARC provides two major services, our Coachella Valley Community Health Survey, which we're here to talk about today, as well as our consulting services. But before I go any further, I want to hear about you. So you should see a poll appear in the middle of your screen. I want to know what sector you represent. And you can check all that apply, whether it's nonprofit, healthcare, education, government, media, or other. Oh, I'm so pleased that this appears to be working. So far, we've had more than 40 of you have voted. Thank you so much. And it's changing rapidly. Fabulous. All right, more than half of you have voted. I'm so glad this is working. Looks like so far nonprofits are leading the pack. It's because we're very cool, and everybody who doesn't work for a nonprofit should at least be involved with a nonprofit. And now let me end this, and hopefully I can share the results with all of you. Here is what our audience is comprised of. A lot of nonprofit, a lot of healthcare, sort of medium education, government, and some media and other. So now that we know a little bit about each other, I'm happy to be able to tailor our questions and our scenarios a little bit better. So thank you so much for joining, and we'll have more polls later on. So stay tuned, stay by your computer and ready to click and vote. All right. In addition to thanking my staff, I really want to thank our board of directors. Janet is representing, but I know many of them are on the webinar today. If we were in person, I would have them stand up and have you all applaud. So mentally do that. They are fantastic people that represent some of the best and the brightest organizations in our valley. We are so lucky to have them, and I am just thrilled and honored to be able to have their guidance. So if you see them, give them a wave. It's COVID-19, so don't give them a high five or anything, but give them a wave and thank them for their service. So I want to talk a little bit now about the survey background. Many of you are very familiar with HARC, and so you've heard this before, but some of you may not be. This picture that I've chosen for this slide is of the Desert Healthcare District, which is appropriate since HARC was essentially incubated there. Years ago, organizations in the Valley were frustrated by the lack of reliable data. There's a lot of wonderful data available at the county level, but our county is huge. It's bigger than some US states. And thus, the data for the entire county kind of actually hid some of the things that makes the Coachella Valley unique and special. So HARC was created to fill that gap. It was determined that we should assess the health of the Coachella Valley by doing this survey. We were guided by a local steering organization and a organization in Orange County, which is since no longer in business, but at the time was doing something like this for Orange County. And guided by a lot of local experts, many of whom are on this webinar today. So again, huge thank you to those of you who were there at the beginning, especially Eileen Packer, our founding CEO, who I know is on today, and Glenn Grayman, our founding board president. Both of these two really guided HARC in the first 8 years and made it what it is today. So again, if you see them, they're responsible for where we are today in a very good way. So together, all of these experts decided that HARC should do a random digit dial telephone survey. That means anyone with a phone has an equal chance of being called, which is very important to being able to extrapolate from the sample to everyone in the valley. It was determined that this would happen every 3 years, be in English and Spanish, include adults and adult proxies for children, because we don't want to talk to children on the phone. That opens a whole ethical can of worms. And the sample size should be about 2,500 in order to properly represent our community. The survey content is wide and very, very diverse. And this is because we don't follow any particular format. We ask our community members, what do you need to know that you can't get elsewhere? And that piece is very important. So for example, somebody might say, well, I want to know about instances of HIV. That is a great question, but public health has fantastic data on that. So I can turn them over to public health. Similarly, whether somebody wants to know something about food stamps, again, there's great data on that elsewhere. We're not here to reinvent the wheel. We're here to get the data that isn't available elsewhere, or take data that would be extremely valuable to know how we compare. So how we compare to Riverside County, how we compare to the state of California. So because of this, our survey content changes a little bit from time to time. You'll see some of the new topics today, but many of the basic building blocks of this survey remain the same year after year. Again, this is our 5th survey. So it covers things like healthcare access, utilization, mental health, prevention, health behaviors, disability, cancer, the whole 9 yards. So it's a very in-depth survey with some great demographics as well. Our job at HARC is to clean, weight, and analyze the data before we share it out with all of you. So that is what we have been working on frantically these past few months. We report out in a wide variety of formats. The first primary method is our executive report, which will be available online today. HARC Search, which is our online query-based tool, special reports, and various media. Most of our data users are other nonprofits, funders, foundations, hospitals, media, education, cities, government, many of the things that you saw in the categories today. Some of the ways that people use this data, which as Conrado mentioned, is very important. If people aren't using this data and it's sitting on a shelf, it was a waste of time, money, and resources for all of us. So the important thing is that we put it in the hands of people like you who can actually do things with it. Many people use it to prioritize health needs in the community, do strategic planning, develop programs, apply for grants, make or change policy, do lectures like these, the whole 9 yards. So now I would like to see from you, let's see if I know how to do this, whether or not you have ever used HARC's triennial survey data before. Again, this is our 5th survey, so we do have 4 previous ones, 2007, 2010, 2013, and 2016. I'm curious if you've used it before, not yet, because I know everybody here will be using it later today. If you haven't used it, but others in your organization have that you know of, and whether or not you're not sure. All right, thank you all for your active participation. I love this. I wish we could be in the room together, but this is still pretty great. Okay. It looks like about half of you have used HARC's data before, so that's wonderful. You are some of the success stories that explain why this data is actually changing lives, and thank you so much for that. On the no, not yet, I'm very excited for you to start using it and hopefully get started today with that. Okay. So because we're a nonprofit, we think a lot about other nonprofits. And one of the things what we're really proud of is that HARC's data helps others to support their requests for funding. This is because having objective data to say, this is really a need here is very, very compelling to funders rather than, I think this is probably an issue, let us address it. So our data has been a small part of many funding requests, and we are so pleased to have been a small part of those. In that HARC's data has helped many organizations fund things like free HIV testing for everyone, Meals on Wheels delivery for homebound and low-income seniors who otherwise probably wouldn't have any food to eat, mental health counseling for children in schools, transportation for people with disabilities, and so much more. So thank you to all of you who have used this data to make great things happen. We are so pleased to be contributing to that in even the smallest way. Okay, so now what you've all been waiting for, of course, is the survey results. Data collection, as Conrado mentioned, was really hard this time. People are not interested in taking a phone call, and it's gotten progressively harder each cycle, but we really put our all into it this time. We did have some paid advertising, and thanks to some of the agencies who are on the webinar today, we did advertising in TV, radio, print, and online in both English and Spanish. And I do think that was effective, but I think what made the biggest difference was those of you who are our partners who selflessly really helped us promote the survey to their constituents, because it's one thing to have a radio ad tell you, this is legitimate, please take this call, it really does help our community. It's another thing to have your senior center or your church say that. And so that's much more compelling, and I think really helped get the word out about the survey and really helped people take the call. You'll see in our executive report a list of many of the partner agencies who helped us get the word out. I apologize in advance if I left anyone out. There were so many of you, and I am so, so grateful for that network of amazing organizations. For the first time this time around, we did some door-to-door outreach. I was a little concerned that given the current political climate, Hispanic mixed status families wouldn't feel safe reporting. Even though we're not a government agency and it would not be tied to any government agencies, I was concerned about perception. So we hired our other partner, Communities for New California, and they did door-to-door outreach for 8 weekends. They spoke to almost 3,000 residents. This photo here is an example of one of the canvassers who's going door to door, giving out literature, answering questions, and if nobody answered, leaving door hangers. They were wonderful and reached so many people. I was so impressed. We focused on neighborhoods that had low percentages of people who spoke fluent English. So that was Indio, Coachella, Cathedral City, and of course the Far East Valley, Mecca, North Shore got some heavy canvassing. So that was new this particular year. We hire Kent State University to make the actual phone calls. When I interviewed with Eileen 8.5 years ago or so, my first question was, who makes all these phone calls? Because that is a lot of work. 500,000 is a lot of phone calls. And I wanted no part of that. So I was very thrilled that these wonderful researchers in what is called a CATI lab, computer assisted telephone interviewing, they are the ones making the phone calls. So they made tons of phone calls. Many of those numbers were not functional or were businesses rather than individuals. Some of them were not actually in the Coachella Valley. Some of them were disconnected, but through the course of 500,000 phone calls, they managed to reach our participants. Another new thing we did this year was each week, one of our participants was randomly selected and won a $100 Visa gift card. We were hoping that this would make participating in the survey a little bit more appealing to people who are unwilling to take a online or a on the phone interview. And I do have to say it was one of the more fun parts of data collection was giving people $100. Many times these people really, really needed it. We got a wonderful thank you card from one woman who won, who said, "Thank you so much. It's my husband's birthday coming up and I wasn't sure I'd be able to buy him a present, and now I am." So it was really heartwarming. We've been fortunate enough that each survey cycle, we've gotten more and more people taking this survey on cell phones. And this is very important because, as many of you I'm sure know, not a lot of people have landlines anymore. And so if you exclude the people on cell phones, you're excluding people who are typically more low income, younger, and tend to be more Hispanic. So in order to capture our total community, we really want a lot of cell phone respondents. And this time we had almost 80% who took the cell phone and completed this survey on a cell, which is really exciting. A lot of the other survey entities that do things like this tap out at about 50%. So we are ahead of the curve on this, and I'm very proud and very grateful to Kent State for that. So our data is huge and expansive, and I'm not going to talk about all of it on this presentation, we'd be here forever. But I want to talk a little bit about some of our new variables this year, because that's always exciting. You can see them listed here on the slide. I also want to talk about significant changes over time. Again, this is our 5th survey, so we're able to see some trends. We looked at some geographic health disparities, and a big thank you to our staff member, Chris, for learning how to map data for this, and just some major issues that are always sort of front of mind and present. So if you don't see something that's of interest to you here, it's probably in the report, and this is just the tip of the iceberg. All right, so let's start with adults. We have more than 341,000 adults living here. About 1 in 4 are living in poverty, and that is as the federal government defines poverty, which is very, very low, for which all of you know who work with poverty and qualifications like that. About half of our adults live in incomes that have a household income of less than $50,000. So again, they may be above poverty, but not exactly wealthy. We have pretty even split between ethnicity. Here's one of our new questions. We're often disappointed that our data doesn't really get a good grasp on homelessness, or people who are experiencing homelessness and what their health is. And that is because the people who are experiencing homelessness may not have a phone, and even if they do have a phone, are unlikely to want to pick it up and take this call because they may be on pay per minutes, et cetera, et cetera. So realizing that is a shortfall of our data. It just does not accurately represent people who are currently homeless. But through our work with CVAG and the Coachella Valley Housing First, we really learned that one of the most important things in the homelessness dialogue is not to just focus on people who are homeless currently, but those who may be about to be homeless. So that's what this captures. We asked participants, what is your living situation today? Unfortunately, most of the people, the vast majority of the people we talked to, have a steady place to live, which is exciting. And as it should be. However, there are thousands, look at that, 5,639 people approximately don't have a steady place to live. That's very, very unsettling. And I'm sure this has increased now with all of the layoffs associated with coronavirus. Admittedly, evictions are stayed, but this uncertainty has likely changed dramatically and is something worth tracking over time. Okay, this is one of my favorite data points, and this is the concept of health insurance coverage. Because most seniors are eligible for governmental health insurance, we're really only looking at those ages 18 to 64, so working age adults. As you can see in this graph, we were not doing well for HARC's first few surveys. The percentage of people who were uninsured just went up and up and up until it peaked in 2013. Over a third of our working age adults were uninsured, completely zero insurance. Then the Affordable Care Act was implemented, and we saw a striking drop to 2016 in the amount of people who were uninsured, which was exciting and due to many of the efforts that many of you partner agencies did to enroll people in Covered California. So my question now, I'd like to do another poll and see how you think insurance has changed. So this is, again, think about it's the percent of working age adults who are uninsured. And how do you think it's changed since 2016? Do you think it went down? And if so, was it a little bit, a lot bit? Do you think it stayed about the same? Or do you think it went up? I know all of us hope that this would be the start of a downward trend where we would get down to eventually zero in an ideal world where 0% of our adults would be uninsured. But this isn't about an ideal world, right? This is about what is really happening in our communities. So I see you're all voting. Thank you so much. And I'll be sharing those results momentarily. I want to give everybody another few seconds to vote. And it looks like opinions are pretty scattered over what you all think occurred with the rate of uninsured. Okay, I'm going to share these results. It looks like the majority, the largest proportion of you, 39%, believe that it went up since 2016 to about 20%. It looks like the next most popular answer is that it stayed about the same, hovering around 14%. And most of the rest of you think it went down a little bit. Okay, so let's see what actually happened. Oh, sorry. I apologize for some of the technical difficulties. I'm still getting the hang of Zoom. So it turns out that you all were right. The majority of you who said, I think it went up to about 20% were correct. It went up to about 21%, which equates to nearly 49,000 uninsured adults. So we've lost some of the progress that we had made with the Affordable Care Act, is people are not as likely to be insured. Not only that, we are lagging behind other regions. In fact, if you take a look at this chart, in the state of California, and this data is from the California Health Interview Survey, of these working age adults, 18 to 64, about 11% are uninsured. Here in our Coachella Valley, it's 21%. That's almost twice the average for the state as a whole. So we are not doing well on that comparatively to the rest of the states or to the nation. Now, we all know that it's not enough to just have health insurance. You have to get care. And so one of the questions we ask is, when you are sick or in need of health care, where do you go to get care? And there are many other responses other than these three. I just pulled these three out for this particular chart because I think it's very telling, and they're some of the most widely talked about ones. So in the report, you will see other usual sources of care, like a clinic, the VA, things like that, or people who have no usual source of care. But here, I wanted to illustrate the fact that the people whose usual source of care is at the doctor's office has gone down steadily from survey to survey to survey. Fortunately, the people who are saying that the ER or the hospital is their usual source of care has stayed pretty stable. We don't want that going up, certainly, because if you're getting your usual care at the ER, you are likely not having good continuity of care. You're not seeing the same provider. It's just not ideal and should be used for actual emergencies. Last survey cycle in 2016, we saw this distinct jump of people who were now getting care at urgent care. That has stayed high, as you can see. Urgent care is still a very popular place for where where people are getting care. So whether that's because of extended hours, whether that's because of long wait times at the doctor's office, we're not sure, but that is still a very popular place to get their care. Now, as I mentioned, it's not enough just to have health insurance, but you also need to get that care. And there are various other barriers that can come up. So on the next slide, I'll be talking about some of the barriers that people said this made it very difficult or prevented them from getting healthcare in the past year. There's a list that they were offered that was fairly extensive, but I just pulled out 4 of them, and I want to see what you think is the #1 barrier to receiving healthcare for Coachella Valley adults. So of all the things out there, not all the things out there, of all the things on the list that was read to them, or in this case, of these 4 things, what do you think is the most common reason why Coachella Valley adults were unable to get healthcare or had it made extremely difficult for them to access healthcare? So far, we've got more than 50 votes, now 60s, now 70s. I love that you're all very active and participating. This is wonderful. Okay. All right, I'm going to end the poll now and share the results. It looks like the most popular choice that you all selected was understanding what is covered by your plan. Let's be honest, health insurance is really hard to navigate, and it's really hard to understand what all is on there. The second most common is transportation issues. Third is hours the provider is open to see patients, and fourth is language barriers. So let's see what the results show. All right. We actually had two tied for the top slot, and that is, you were correct, understanding what is covered by your plan, as well as the hours that the provider is open to see patients. So again, if you're a working adult and you are not, not salaried, or you don't have a flexible employer, it's very hard to get in to see the doctor if they happen to operate on the same schedule that you do. Taking time off work is also a big barrier. Down there at the bottom, transportation is actually one of the least common barriers, although it still affects thousands of people. And language barrier prevents about 5% of our adults from receiving care. Okay, moving into health behaviors. We asked a question this time around that was new to us. And this is whether people have used marijuana, hashish, or another THC product in the last 30 days. It turns out that about 1 in 5, or 21% of our local adults have used marijuana or some THC product in the last 30 days. We took a look at this geographically. It looks like, generally speaking, the area with the highest percentage of marijuana users is in the Palm Springs area. But again, this is Coachella Valley-wide data, not meant to represent any individual city, which is why you see ranges there, not precise numbers. And it's mapped by zip codes, not just by cities. So it looks like our marijuana use varies across the valley, but it's definitely relatively high in the Palm Springs general vicinity. So as a follow-up to this question, we said, okay, so you're an active marijuana user. Why did you use it? Did you use it for medical reasons, like to treat or decrease symptoms of a health condition? Did you use it for non-medical reasons, like to have fun or fit in, or for both? And you can see that it's pretty evenly broken out, about a third, a third, and a third, in terms of why people are using marijuana. So I want to move on to another health behavior, and one that we've tracked for 4 surveys now, and that is the behavior of getting tested for HIV. So it is absolutely critically important that people are tested for HIV. Here in our valley, we have prevalence of HIV is twice the national average, and if you don't know your status, you are much more likely to spread it to others and to be able to not control your own health. So for the first time in all of our surveys, more than half of our local adults have been tested for HIV at least once. I hear everybody mentally at DAP cheering. It's been a long road to get there. This used to be much slower. So that's very exciting. 51% have been tested for HIV at least once, which is what the CDC recommends. The flip side of that, of course, is that the other 49% have never been tested and don't know their status and need to get tested as soon as possible. And it's not evenly distributed across our valley who's been tested and who hasn't been tested. David Brinkman with DAP is very excited about this data. I knew he would be. We definitely have some pockets in the far East Valley and in that sort of Central Valley, Palm Desert, Indian Wells area are not tested at rates the same as the Palm Springs and Rancho Mirage area. So there's definitely pockets of area in the Coachella Valley that need some attention. These people need to be educated that even if they don't think they're at risk for HIV, they should be tested at least once. Next up, I want to talk a little bit about major disease. We do have the same 3 top major diseases as we have in prior years, and that is high blood pressure, high cholesterol, and arthritis. These are very common, and I have 2 of them myself, so it's understandable, but this means this is what our medical care providers are treating on an everyday basis. People are coming in with these chronic disease. I want to move on to disability. So disability is a relatively new question on our survey. We started asking questions about this for the first time last cycle in 2016. And that's because we really heard from the community that they really want to know how many people are disabled. But the reason that hasn't been measured, or the reason that that's not typically measured on many surveys, is because it's hard to define, and it's hard for people to agree on what constitutes a disability. So we took the sort of ADA definition of what a disability is and turned that into a question. And we found that 22% of local adults are limited in some way in their daily activities because of a physical, mental, or emotional problem, which is the strict ADA definition of a disability. So that's almost a quarter of our local adults. We also asked further question about sensory disabilities. So it turns out that about 11% of our local adults are deaf or hard of hearing. And if you consider that this is actually a telephone survey, this number is likely quite a bit higher, since the very severely deaf may not be the ones who are able to communicate via phone. We also have 9% who are blind or low vision. So again, these are the types of issues that are common in our community, and that we need to make sure that these people are not left out of our conversations about health equity. Next, I want to talk about behavioral health or mental health. This is a very hot topic here in our valley, as it should be. As you can see, almost 30% of our local adults have been diagnosed with one or more mental health disorders. The most common ones wouldn't really surprise you, right? It's depression, anxiety, and PTSD actually saw a significant increase this year in the number of people who'd been diagnosed with PTSD. It went up from, I believe, about 5% to now 9%. So that's gaining quickly. But mental health isn't just about diagnosed disorders, right? There's a lot of other aspects to behavioral health. So as a result, we also asked them, have you had an emotional, mental, or behavioral problem in the past year that really concerned you, whether that was something like stress or grief or depression? And we've got about a third of our adults had something like that. We asked some follow-up questions of both the people who have a diagnosed disorder and these people who have a mental health concern. And overall, about 13% of these needed mental health care in the past year and couldn't get it. So this equates to more than 18,000 people who needed mental health care in our past year and could not get it. I know many entities out there are striving really hard to address this and to provide low to no cost mental health counseling for everyone. And those efforts are definitely still needed, as illustrated by this 18,000 people who are in need of mental health care, and are obviously still a very high priority. Next up, I want to talk about one of our brand new questions, which is loneliness. I do a lot of work with senior serving agencies in the Valley. And one of the things that comes up often is loneliness and isolation for seniors, and the perception that this is a major issue. So we asked this new question: how often do you feel lonely or isolated from those around you? And as you can see in the chart, most people are pretty healthy. They're experiencing loneliness never or rarely, which is fantastic. But more than 20,000 local adults, feel lonely or isolated often, and another almost 9,000 feel lonely or isolated always. So this is a major problem for these individuals. That's almost 30,000 people who feel lonely or isolated often or always, and that's not a good, healthy way to feel. So this just emphasizes that the efforts that are being made to provide contact for individuals is something that's so important. I'd be really interested to address this question now in the era of lockdown and shelter in place, and see how many people are feeling lonely or isolated now. I think that would be really fascinating. So if anybody wants to do a study on that, contact me afterwards. But I think this is an important thing that we start measuring and perhaps continue measuring throughout the next survey cycles, because this is something that isn't often covered. Many times, because surveys cannot assess everything for everyone. They are limited to diagnose things, but things like loneliness and isolation are very impactful on your quality of life, even if it's not a diagnosable disorder. It is something that can be addressed, and it is something that could maybe be addressed a little bit easier. So this is something that I think is a great measure that we need to continue assessing. Next up, obesity. This used to be the hot topic in health and wellness. It's not anymore. People don't like to talk about it, and I think because it hasn't really changed. It's hard for it to be the hot topic after after so many years and so many dollars put into the effort of addressing this. But as any of you know who've tried to diet, addressing obesity is hard, and it's especially hard on a population level. So it's not terribly surprising that we still have a lot of people who are overweight or obese, but it is unfortunate, and it is something that needs to be addressed. Not only that, we ask people their height and weight so that we can calculate their body mass index. Now, BMI is not always a precise measure of body fat. There are some people who are super fit whose BMI says that they are overweight, when in reality it's all muscle. But for the most part, it's pretty accurate for an estimate of whether or not you have a healthy body mass. So we calculated that, and as it says here, 66% of adults have a BMI that puts them in overweight or obese. And then we subsequently asked them, how do you feel about it? Do you think you are overweight, underweight, or about the right weight? And of the adults who had a BMI that put them in the overweight or obese category, 39% said, oh, I think I'm about the right weight. So they're not realizing that they're overweight or obese, which means they're very unlikely to actually change their behaviors, right? Because why change if you're about the right weight? So they're very, very likely to stay overweight or obese. And this is an indication of the fact that education needs to be done, or this problem is never going to go down. Okay, so next up is another one of our new questions, and I want to do a poll about this. It's obviously very, very important to maintaining a healthy body weight is the ability to exercise. Exercising and eating right are really the only two things that influence that. And you need to be able to exercise affordably, right? Not everybody can have a gym membership. Not everybody wants a gym membership. So it's often important to be able to participate in recreation outside your own home, whether that's going for a walk, going for a bike ride, or going for a hike locally. So for the first time, we've usually asked on the child survey, does the child have a safe place to play outside? But it's an important question for adults too. So this year we added this question to our survey. Do you feel that you have a safe place to walk, bike, and or hike in your neighborhood? It looks like most of you have voted. We've got about 75 people have voted. So I'm gonna end this and share the results with you. Looks like 89% of you say, yep, you have a safe place to walk, bike, or hike in your neighborhood. I know I definitely feel safe walking in my neighborhood. We have a lot of kids, a lot of people walking their dogs. It definitely makes me feel safe. But 11% of you said, no, I don't have a safe place to walk, bike, or hike in my neighborhood. So that's a lot harder for you to actually get some outdoor recreation. So now let's see how that compares to our valley as a whole. Almost spot on. In our valley as a whole, 91% said that yes, they have a safe place to walk, bike, or hike, while 9% said no. And it's one of these things where, yes, 9% sounds little to some people, but that equates to more than 30,000 people. So more than 30,000 of our local adults don't feel that they have a safe place to exercise outside in their neighborhood. This has implications for things other than exercise as well, right? It can be stressful if you feel that you live in an unsafe neighborhood. But it's absolutely something that has an impact on your life as a whole. So this is something that we are very interested in. And before anybody asks, it's not a high enough number for us to actually map. So we can't see where these people live without violating their confidentiality. So we don't have a map on that one, as interesting as that would be. Okay, next up, I'd like to talk a little bit about food insecurity. Food insecurity is still a problem here in our Coachella Valley. I know those of you that work in the sphere, this is not a surprise to you in the slightest. You know that there are thousands of people here who need your help, especially now in coronavirus times. But even in 2019, 21%, so that's 1 in 5 local adults had to spend less money on food because they had to prioritize other basic needs like their rent, their electricity bills, other things like that that they deem absolute necessities. We have a lot of stress about worrying whether their food will run out before they can get money to buy more. And 1 in 10 have to cut the size of meals or skip meals because they don't have enough money to buy food. And unfortunately, nearly 13,000 local adults have had to go for an entire day without eating because they didn't have enough money for food in the past year. So on that sobering note, let's move on to children. Not to say that it'll get a whole lot better, but we have more than 88,000 children here. Again, much like our adults, we've got a large percentage who are living below the poverty line, and many of them are living in households with an income of less than $50,000. So poverty continues to be an issue here. One of our newest questions is the idea of adverse childhood events. And some of you are super familiar with these, and some of you, this may be your first time hearing about them. Adverse childhood events or adverse childhood experiences, ACEs, are things that happen in childhood that have been linked to very serious health outcomes, morbidity, mortality in later life. And so children who experience one or more ACEs are significantly more likely to have many major diseases, many earlier death, poorer outcomes in life in general. It's some very scary stuff. And as the number of ACEs that they have experienced goes up, so does their likelihood of experiencing these negative outcomes. So there's many types of ACEs: abuse, emotional, physical, sexual, neglect, emotional or physical, and household instability. Our particular survey focused on household instability. And this is definitely, I would say, the least serious of the ACEs, but it's the most appropriate for this particular survey. Because we are not talking to the child themselves, we are talking to an adult proxy for the child, you can understand that it's not really appropriate and it's not likely to get accurate data if we ask them whether the child has been abused. They may not know, or they may be the abuser, and in which case they have significant motivation to not tell the truth and not report. So for all those reasons, we didn't ask those questions about abuse and neglect. We asked 4 questions about household instability: whether they had a parent separation or divorce, whether they'd had anybody in the household had been incarcerated during that child's lifetime in prison or jail, whether anybody had mental illness or substance abuse in the household, and the witnessing of domestic violence. So our results show that 41% have experienced at least one of these 4 ACEs. The most common, I'm sure this is not a surprise, is experiencing a parental separation or divorce, which I think we all agree is not fun for anyone, but definitely the least frightening of all these potential outcomes. We also mapped where the greatest percentage of the child population has experienced 1 or more ACEs. You can see that we've got some sort of hot spots in Palm Springs as well as in Thermal and Oasis, although there is a lot of missing data there where the population counts were just not high enough for us to map accurately. Access and utilization for children is something that always gives me great hope. The majority of our children have some type of health insurance. Technically, they should all have health insurance because all low-income children are eligible for Medi-Cal. So again, those of you who are working on enrolling people in Covered California, your job is not done. It is mostly done, but it is not done. We still have about 5% who are uninsured. Fortunately, 81% of our local kids have had a routine checkup in the past year, so they're getting that, most of them are getting that continuity of care. Mirroring their adults, they're getting their usual source of care at the doctor's office or at urgent care or at one of our fabulous clinics. And 83% of children have visited the dentist at least once. I encourage you, when you get the report, to go to this section. It's very interesting. Ideally, the child would be going to the dentist before their first birthday or when they get their first tooth. And the kids are going to the dentist, but not that early. I want to say it's about 17% went before they were 1. And the rest of them are going later on. So for those of you working with early childhood education, definite education opportunity to educate the parents that even if the kid only has 1 or 2 teeth, they should still be going to the doctor before they're going to the dentist before they turn 1. It's very interesting data, and I think you'll find that section fascinating. Another question that we asked for the first time was about water safety, and it's a big thank you to First 5 Riverside for bringing this to my attention. Drowning is the #1 cause of death for kids ages 1 to 14. That's a huge deal. #1 cause of death. And here in our Coachella Valley, we're blessed by a gorgeous weather, but that means almost everyone has access to a pool. I think mine is the only housing complex in the valley that doesn't have a pool. But even crappy apartments have pools, just not mine. So there are an abundance of opportunities for these children to drown, so it's very important that they know how to swim. Fortunately, 74% of our local children know how to swim. Very good. But that means 26% do not. That's 1 in 4. 1 in 4 kids don't know how to swim. So I broke it out by age because, of course, I don't expect all 2-year-olds to be Michael Phelps, right? But I expect that by the time they get older, they will know how to swim. So I broke this out to examine that. And it's certainly the case that the 2 to 3-year-olds, the majority of them don't know how to swim. By the time you get to 4 to 5, you're at least over that halfway point. More than half of them know how to swim, so that's encouraging. But it's definitely not as high as you would like it to be and not as early. I learned from First 5 Riverside that there are water safety courses for infants as young as 6 months. I had no idea about this. It's essentially teaching them to roll over and float on their backs until help comes. But they can really do water safety at a very, very young age. And that's something that's really important here in our desert, what with all the pools and drowning being the #1 cause of death for young children. All right, moving on to behavioral health. We ask questions about children ages 3 and over. For those of you with children younger than age 3, I'm sure you can testify to the fact that they're all crazy. In a good way. But we want to assess age 3 and over because that's really when it begins to be easier for physicians to diagnose with issues. So about 1 in 4, about 1/4 of our children age 3 and over have difficulties with emotions, concentration, behavior, and or getting along with others, according to their parent or guardian proxy. And about 18% have been diagnosed with 1 or more mental health disorders. The most common of these, I'm sure you're not surprised, is ADD, ADHD, followed by anxiety and developmental delay. Next up is sleep. It is very important for a growing child to get enough sleep. It's very important for adults to get enough sleep too, but especially when their brain is developing and everything. And you can see that the National Sleep Foundation really recommends a lot of hours of sleep for the very young children. Even as much as in their teens, all kids should be getting at least 7 hours of sleep a night. And so we asked how many hours of sleep the child got on average and calculated it combining their age with these recommendations from Sleep Foundation and found that roughly 5% of our local kids are sleep deprived based on these guidelines. So fortunately, that's relatively small. Could be better, but definitely encouraging. Okay, next up is obesity. Now for adults, we ask their height and weight and we calculate BMI. For children, it's a little bit more complex. Generally, the way that is generally accepted, which is how we calculate it, is assessing BMI for age percentiles. So that takes into account height, weight, age, and gender. This is an example of a map of how you calculate this and what counts as overweight, obese, healthy, or underweight. It obviously depends a lot on the child's age, and we only ask this of children aged 2 and up. It's very hard, it's not impossible, but it's hard to calculate this for the younger children. It's something that needs essentially a physician to do some pretty precise measurements. So much like the adults, obesity remains an issue in our child population. About 46% of children aged 2 and over have a BMI for age percentile that puts them in the overweight or obese category. Notice that's better than adults, right? We had 66%, so the kids are doing better than us. We get fat later. But it is still a major problem, right? This is still something that is threatening their health and that needs to be addressed. And the part that I think is most concerning is of those kids who have a BMI for age percentile in the overweight or obese category, their parents don't realize that. In fact, the majority of their parents think that their child is about the right weight. And this is very telling, right? Much like the adults who aren't going to change anything in their lifestyle because they think they're about the right weight, parents are not going to change anything in their child's lifestyle either. And the parents are the ones who are buying the groceries and dictating the kid's schedule. So unless the parent is on board, the chances of the children changing their behavior spontaneously and getting healthy and getting that BMI down to a healthy weight is very unlikely. So the fact is that there needs to be some conversations with parents and some education about what overweight and obesity looks like. Last cycle, I was able to divvy this up by age, and I'm really looking forward to doing that again this time, because last time I found that the percentage of children who are overweight or obese is pretty steady across the age group, right? Whether you're 3 or whether you're 13, pretty even chances of being overweight or obese. The parent perceptions, though, not even. Parents are a little bit better at accurately judging their older children, but the younger children, nobody thinks their younger children are overweight or obese. They think, it's cute, chubby, it's baby fat, when really that is something that's already setting them up for some serious health consequences. So there's another educational opportunity. Food insecurity is not just an adult issue, which I'm sure all of you in the food insecurity world know. We've got a lot of concern among the parents and guardians about their ability to buy food. A lot of households that these kids live in that have to spend less money on food than they want to, and kids having to cut the size of their meals or skip meals entirely due to lack of money. And it's very encouraging that for the most part, many of these children don't have to do this because they're getting free and reduced price lunch at school. Right now with the school closures, I know Fine Food Bank is trying to address that gap and fill that gap, as are the school districts. And I applaud all of your efforts, because without those efforts, I'm sure these numbers would be much, much higher. So the things that you are doing to make sure the kids get fed during this time is very important, because even with those in place, we still have this level of hunger. All right, the next slide is one of the ones that I think is the most intriguing. We ask parents and guardians of children ages 6 to 17, have you or another adult in your house had a conversation with the child about, and there's a large list. The 5 that people are most discussing with their kids, top of the list is smoking, vaping, cigarette use, tobacco use, etc. 71% of parents of kids 6 to 17 have had that conversation with their kids, have had the conversation of don't smoke, don't vape, etc. They've also talked about drugs. Racism is a brand new one that we added this cycle, and it looks like the majority of parents are talking to their kids about racism, which is encouraging, I think. And the other new one is talking about social media and sharing of private pictures online, and whether or not that's appropriate, et cetera, et cetera. So the majority of parents are having those discussions with their kids. Now, when you go over to the other side of the slide, It's the ones that are least commonly discussed. And I find it interesting that while the most commonly discussed are really around sort of consumption health behaviors, smoking, drinking, doing drugs, the least commonly discussed are frequently around mental health, right? It's self-injury, like cutting, is the least discussed. Eating disorders, domestic violence, interpersonal violence, suicide, and depression or isolation. So these conversations are not happening in the home. Whether those conversations need to happen elsewhere to give these children the coping skills that they need is probably something worth discussing, and what is the appropriate venue for these discussions. But it's not happening in the home currently. Okay, so as I mentioned, that was a very brief snapshot. I now want to turn to what's next. So our executive report is 140 pages of beautiful, beautiful report that we all worked very, very hard on. Starting at 6 minutes ago, the report should be available for you to download on our website. You can go to harcdata.org. You can go to this full link, but just click on free data and it'll take you there. You do need to answer a quick, brief survey about yourself and how you plan to use the data. I apologize for making you do this, and I know some of you absolutely hate it, but it's a way for us to track the impact of this report. You know, who is it going to? How can we measure the difference it's making in people's lives? So while I know it's annoying to fill out the little survey, it's like 4 questions, please, please do it. It helps us keep this data free because it helps us quantify to our funder how important this report is. So you should be able to download that today, right now. And if you have problems, I'm throwing my administrative manager at your feet. Teresa Sama is available. She'll be on email in case you need it, or if you have any technical difficulties. Sorry, Teresa, really hope you don't get swamped by this. Her email is tsama, T-S-A-M-A, @harcdata.org. And she will be there to, I'm seeing not available yet, page not found. So Teresa will be getting on that and make sure that it's available in the next half hour or so. Teresa, write that to all attendees as well. So very exciting. In print, we have our fabulous vendor, Ace Printing. They are running a little behind due to coronavirus, which I'm sure you all can understand, but they hope to give us the, Teresa, you're writing to all panelists. You need to write to all panelists and attendees, because all panelists is just me. So as I was saying, in print, we have beautiful bound copies that will be available at the end of this week. And City of Palm Desert gave us a grant to do this event when we thought it was an event. And they were kind enough to let me spend the money, instead of on catering and room rentals and all of that, to spend the money on mailing these hard copies to you. So completely, the first 500 of these are completely free. So if you want to have a mailed copy, I understand some people don't care about a mailed copy. They like their PDF. Super awesome. But if you do want a mailed copy, you can go to surveymonkey.com/r/HARC2020. Just enter your name and mailing address, and that will alert us that we need to mail one out to you. We hope to mail them out early next week. And let me tell you, they're super beautiful. I'm really proud of it. And this is very secure. We won't use it to mail you anything else unless you want something else. So feel completely safe. And again, huge thank you to City of Palm Desert. I wrote to them sort of frantically in a panic at the end of, 2 weeks ago and said, please, can I repurpose this money? I really need to repurpose this money. And they were very kind, because I'm sure in the midst of their coronavirus panic, they had 8,000 more important things to do than answer my email about reallocating funds on a particular grant. So I'm very happy to be able to mail these out to you. We are prepared to do so, and Also, after the pandemic is over, we'll have copies in our office. For now, we're not there, so please don't stop by. It's not safe for any of us. So please ask for it via mail, and we'll make sure that you get a copy as soon as possible. Now, we also have an online searchable database called HARC Search, and you can use to look at the variables across time, right? So from 2007 up until this 2019 data. And you can also cut the data to examine populations of interest. I saw several comments coming up, whether it was just to me or to everybody, that were saying that they want to see this by ethnicity, or they want to see this by gender, or they want to see this just for 0 to 5. All of that is possible on HARC Search, or for the majority of variables. However, we had some unfortunate, we hired the wrong web company who was not able to deliver a data set as they said they could. So we are working to make up that with a different vendor, and the 2019 data will be on the new and improved site sometime this summer. I apologize that it's not there today, but it gives you something to look forward to. It's also free, just means you have to sign in, create an account. Again, this is just a way for us to look at who's using this data and really help our funders understand the impact. So HARC Search, again, still a useful tool to look at the old data. I welcome you all to go there now, but the 2019 data won't be up until later in the year. If you have an urgent need for something, like say, Jenna, I need 0 to 5 on water safety. If you need something like that, just shoot me an email. I'm happy to run it for you. You guys are our valued partners, and we want to make sure that this is as useful as possible. And so in the meantime, before HARC Search is up and running, just shoot me an email and I will do my best to get you the data that you need. Additionally, that's not all we're doing. We will be doing some trainings on how to utilize the data, how to put it to work for you, how to find other good publicly available data. Our director of research, Casey Lear, is super awesome at giving these trainings, and I will probably delegate to her for all of these as well. So you can look forward to that. We'll let you know when those happen. And as I mentioned, we can do some custom data runs for you. Just ask. If it's something I can't do without breaching confidentiality, you know, if it's something that has too small of a sample size, I'll just let you know, but it's always worth asking. This data will also be used as a piece of Desert Healthcare District and Foundation's upcoming Community Health Needs Assessment. Now, many of you may have heard about this project. They did a press release 2 weeks ago, I think, about this progress. And it may be a little confusing because HARC is lucky enough to not only be a Desert Healthcare District grantee, but we also happen to be their contractor that was selected to do this work of the Community Health Needs Assessment. And we are so honored to be a part of that project. And I wanted to differentiate a little bit between the data that you see today, our triennial survey data, and Desert Healthcare District's Community Health Needs Assessment. Our data will definitely inform that assessment. It will be a big piece of it, but the needs assessment will also collect data from so much more. It will include data from our wonderful partners, whether that's public health, whether that's Borrego, whether that's the hospitals. And so it'll be a very comprehensive multi-source assessment of our community's needs that includes HARC's data, but goes beyond that as well. So we are looking forward to producing that report with the district within the next year. We also will be producing specific trend reports for Desert Healthcare District. This was a part of our grant to do this survey. So because we are now in our 5th iteration, many of the things we can look at in 5 points in time. So we'll be looking at this to create these reports. And since Desert Healthcare District is a public entity, they will be available for free no later than October. And these reports will cover things like health insurance and utilization, mental health, social economic needs, and major disease. We also plan to hopefully get some funding to do some special reports. We've done these in the past whenever we could get funding to release in-depth reports on specific segments of our population. So for instance, last cycle, Grace Helen Spearman Foundation funded a special report on people with disabilities, which compared our local adults with disabilities to those who don't have a disability, and seeing how those differ, what issues are especially prevalent for people with disabilities. The Allen Foundation also funded a special report on seniors, which was very interesting and well received. And so when we have funding, we'll do more special reports. So now I want to go to my last poll for you all, if I can figure this out, and go to special reports. Okay, I want to know what special reports would be most useful or interesting to you and the business that you do. Obviously, there's a bunch of potential options, and this is only a few of them, but I'm interested to see what's most in need, and then from there, I will try to find funders to fund those, maybe in that order, so that we can get the information that our partners need out to the community as soon as possible. We want to be sure that these special populations get the attention that they need. As I mentioned, our data is for the entire Coachella Valley. And so if we want to do some drill downs and look at health disparities, make sure we're promoting health equity, that's going to be very important, some work that will be done with these special reports. Thank you all for voting. Okay, I'm gonna end the poll and share the results now. Looks like many of you, the majority of you, are interested in a special report on behavioral health, so I will tackle funding for that first. Looks like poverty is also a big interest. And all right, I will be pursuing some funding and try to get these reports so that we can get this out to you. I know they're all really interesting and really deserving of attention, but we definitely will take them one at a time and see what we can do. Okay, now I would like to move to Q&A. You can see here on this last slide, this is my contact information. As I mentioned, we're not in the office, so please don't call that phone number. No one is going to pick up. But if you do want to call and leave us a message, we will get back to you within 1 business day. But if not, or if you want a tighter turnaround, the best way to reach me is via email. We are located in the RAP Foundation building. A huge thank you to RAP. We love being there. We love being co-located with all the other great nonprofits there. And now let me go back through our chat and see some of the questions you've asked. Some of them have been asked to the whole public, and some of them have just been directed to me. So if I'm reading a question that you're like, she's making that up, it's a question that somebody sent specifically to me. I promise I'm not making it up. Let's see. Okay, one question. Will you share your slide deck today? Absolutely. I am so happy to do that. And so I will make sure that everybody who attended gets the slide deck. We'll make that available on our website. This video will be available on our website shortly as well. And so you can have both if you just want to flip through and not listen to me talking. I know that's much more convenient. Comment. Bravo, Eileen and Glenn. I do just want to highlight them again. They are our founders. They are also donors. They're super awesome. Everybody give them a mental round of applause. HARC would not be here having this webinar today if it wasn't for them. This is in reference to our uninsured data, and that is on, it says, isn't 18 to 64 quite a wide range? Is this broken down by increments? Super good question. And that's something that will be on HARC search at a later date to see where you can break it down by age in some more subtle groups rather than just 18 to 64 working age adults. That is also something I can pull for you if that's something you need for a grant proposal or something right now. I can get that to you. But in general, in our insurance section, we do respond, we do look at working age adults because those are the ones who aren't eligible for Medicaid. Let's see, Les Zendel on the board of Desert Healthcare District asked, how do you know that the sample of respondents you got reflect the total population of the Coachella Valley? Trust Les to ask the complex questions. Part of the reason that we do a random digital telephone survey is that random sampling is the golden standard in terms of making sure that your population, your survey population is representative of the whole population. There are several different ways to do random sampling. You can do address-based, but that requires written surveys, which presumes a certain level of ability to read, which unfortunately often is not there. And so we choose to do phone surveys instead. Then as a further measure, we have a statistician who weights the data according to gender, race, ethnicity, age, and cell phone versus landline use. So these demographics match up to the US Census data. So again, this just underscores the importance of why everybody should take the census. I strongly recommend, if you haven't done it, you should do it now, because it's so important that we not undercount. And I know there's a lot of you who are working on making sure everybody gets counted in the census 2020. Thank you all so much for your hard work. Let us know at HARC if we can help with that, because it's absolutely not useful unless we get counted. Connie asked about how the results break out according to ethnicity. Again, that's something that will hopefully be on HARC search, but if you do need that immediately for any one particular variable, just let me know. We tried to break that out in the report whenever we could, but to be honest, it would be about 500 pages real fast. So that is something that we recommend that you try on HARC search. And again, since 2019 data isn't up, if you need me to run that for, I know Connie's most interested in reading to the child at home, you can just shoot me an email and I can do that. Louise asked how these behavioral health numbers compare to the state, county, and nation. And that is a great question. Wherever possible, whenever we ask the same exact question as another survey, such as the California Health Interview Survey from UCLA, or the CDC's Behavioral Risk Surveillance Factor Survey, BRIFIS, whenever we ask the same questions, those are represented in our report. So you'll be able to see how we stack up. Some of them are better, some of them are not, and some of them there aren't comparable data, but whenever possible, we try to tie this to the state, county, and the nation. So you will see that in the report if it's available. One question, how can we best battle against obesity when access to healthy food and lifestyles are based off economic disparities? Very good question. And that is one thing that I think we need to address together as a community, because those of you with expertise in, boots on the ground, interacting with community members can answer one way, I can answer another way based on the data. It's something we need to collaborate together on, and I don't have a clear, this is what we do answer. I wish I did, really do. Walker Beverly asked, do you have criminal justice data? Very good question. And the answer is no, because that's one of those things, again, where we don't want to reinvent the wheel. If somebody else has great data, we don't need to collect that data. So the FBI crime statistics are where we get most of our crime data for other projects, like the Desert Healthcare District Community Health Needs Assessment. I strongly recommend you check that out. They have data by reporting agencies, so you can essentially go by police department. But that's one of those things that we don't collect because somebody else is doing a fantastic job already of collecting that. The closest thing in our data set is that data about whether or not a child has had a family member incarcerated. One individual said, is the search available by zip code? The short answer is no. This data is meant to be representative of the Coachella Valley as a whole. So we're very hesitant to represent at lower levels than that. Often people want to say, well, I want city-specific data. What is this like for Palm Desert or Palm Springs? And the only way we're able to do that is by proactively oversampling those cities. So we would have had to collect extra data to be able to make those calculations. In some prior cycles, we've been able to do that. I think the most recent one, we did an oversample of desert hot springs in 2013. I think we did an oversample of Indio back in 2007. But aside from those oversamples, we cannot speak to smaller geographies like a zip code or a city. It's just not a good idea to base those numbers on such a small population. So that's not to say that we don't sometimes break things out by zip code. We're doing that a little bit for our project with Desert Healthcare District, but we try to make sure that we are representing minimum sample sizes and doing best practices to make sure we're not leaping to conclusions. So in general, we don't have results available by zip code for the general public. Susan raises an interesting question. Is it possible that people who agreed to answer the survey questions are people who have more health problems and concerns versus the general population? That is a solid question, and honestly, not one that I know how to answer. That's something I'll have to think about. I mean, it's certainly, right, if you need services, then you're more eager to tell someone you need services in the hopes that they'll get addressed. So possibly. Yeah. Roseanne said, is the Native population included? Yes, about 3% of our adults and about 3% of the kids are of Native American, Alaska Native heritage. It's actually higher than it's been in previous years, which is really exciting because they are such an important group that needs to be properly represented. Jonathan asked, how often does HARC do webinars for the community? And would you be willing to do a webinar in the future? Yes. In the past, we did things in person a lot more, but that's obviously out the window now. So we would love to do webinars for any of you, and this goes for all of you. If you do want this presented to your board or to your students or to something else, it's HARC's absolute genuine desire to get this out to the very people who can use it. So we want as many people as possible to know that this data is here and to use it and to make great things happen with it. So in the interest of that, we are so happy to do webinars. We are so happy to do guest lectures. We want to be there. We want to communicate this results. We are happy to do that. Joe asks, how much would the poverty data change if cost of living were considered? And I would say, I'm not an expert on that particular subject, but my instinct is drastically. I think that there has been a lot of discussion about how the federal poverty level is a massive underestimate. I certainly know that if you're, a family of two and you make $20,000 a year, I can't imagine living on that with my family of two. So to me, that's poverty. I mean, but poverty hasn't been recalculated in a long time. So I very much think poverty data would change if cost of living were considered, but that's not how the federal calculations are made currently. So I went with the federal guidelines, but I absolutely agree that it will change. Tommy Clinton wants to know, how are you ensuring that the transgender community is fully represented in the data? We did ask gender in the two-part question that the Williams Institute recommends. So we are able to pick out those individuals whose current gender identity doesn't match their birth gender, and as well as those who identify as transgender. Unfortunately, we don't have a large enough sample size to pull out their own separate report, but we do know they're in our data and we are very happy to include them. Oh, Felice wants us to do a HARC app for smartphones and tablets. Wow, you're ambitious, Felice. I have no plans for that yet. Right now, in the midst of coronavirus, I'm mostly planning on how we can stay in business, but I would be happy to explore that. Bill says a client wants to strengthen their grant proposals by including HARC services in their proposals. How could HARC help them? That is a very good point, Bill. Not everything we do is encompassed in this free data. So if you are writing a grant proposal and you do want anything related to data, do you want us to crunch your numbers? Do you want us to help you design surveys? Anything you want, please come talk to us. It's free. We'd love to help you write something that goes into your proposal with the understanding that then if you get that grant, you then hire us with the funds to do that work. And we really want to collaborate on these proposals and make your proposals stronger so that you are more likely to get the money to do your services and to measure that impact. Bev asks, since you've been doing this a number of years, are you seeing any trends that stand out? We'll be very interested to see the breakout on the high blood pressure numbers. So some of those trends are represented in the executive report, but a lot more will be in those trend reports that come out for Desert Healthcare District. I'll be really interested to see some of those too. You know, some things, most major diseases tend to stay pretty stable, but some things are really changing, and I'm excited. I was really surprised to see that PTSD, PTSD significantly changed diagnoses this past time. When will the Desert Healthcare District report be completed? So that is, I assume, in reference to the Desert Healthcare District Community Health Needs Assessment that they've commissioned, that HARC is working on. And we hope to have that out in January 2020. Needless to say, coronavirus is throwing a wrench in everything. So it might be then, it might be a little later. It depends on when our partners can get us data, but we are hoping to have that out in early January. Oh, yep, January 2021. January 2020 is gone already. If you're asking about the trend reports for Desert Healthcare District that are part of our grant, I know it's Desert Healthcare District and HARC are such great partners, but it gets a little confusing as to all our different projects that we're on. Those trend reports on those 4 topics, those will be out by October 2020. Lisa Ford asked, hi Lisa, if PTSD changes significantly, doesn't it make sense to focus on the military special report? I think that would be really interesting. I am probably biased because I am married to a veteran and I'm a Vietnam vet's daughter. So I think that's super interesting, but we'll see if I can get funding for it. And it's important to note that not all PTSD is linked to veterans, right? There are many instances where somebody might experience a traumatic event that gives them PTSD. So it's not necessarily mapping perfectly onto the veterans. Okay, I realize that I have gone over time and I try really hard not to do that. So I wanna thank you all so much for tuning in today. I hope that you are able to access the PDF. I hope that you enter your mailing address onto that SurveyMonkey. It should also, when you close out of Zoom, it should go to that particular SurveyMonkey site so that you can enter your address and we can mail you a copy for free. Thanks again, Palm Desert. And thank you for participating. We do this for you, so it's really satisfying and gratifying that you're all here. So stay safe, stay healthy, take a look at the report, let us know if you have questions, and I hope you do great things with it. Thank you all.